Now we start with the first talk. It's transition from conventional extracapsular cataract extraction to manual small incision cataract surgery. As you all know, cataract surgery is the most common common surgical procedure performed on humans. Success of which is determined by quicker and visual functional and recovery, and is closely related to the size of the wound. For the last few decades, we have seen a steady and progressive worldwide maturation of our extracapsular surgical skills. Now, why do we have to learn SICS? Clinically, it provides a safer intraoperative environment, a faster and safer post-operative course, smaller incision, and maximum astigmatism control. It's a cost-effective and technically easier and safer procedure. It's an ideal stepping stone to mastering phacoemulsification. Well-structured training program, willingness to change, and an easier learning curve are the factors that have significantly increased the number of surgeons taking this procedure. Better wound stability, reduction of induced astigmatism, less chances of AC collapse during surgery, suture and suture-related complications can be avoided, greater patient comfort, and fewer post-operative follow-up visits are the advantages over conventional ECCE surgeries. While during the learning curve of SICS, an ideal case selection is very, very important. You should select cases which have a good cornea, a well-dilated pupil, earlier nuclear sclerosis like grade 2, posterior subcapsular cataract, and wet mature cataracts. Cases with having endothelial dystrophy, pseudoexfoliation, small pupil, subluxated lens, intumescent cataract, Morgagni cataract should be avoided during the early learning process. Manual SICS has an easier learning curve if one makes the transition after mastering ECCE. Challenging steps being prolapse of nucleus into the anterior chamber, removal of nucleus from the anterior chamber, and scleral tunnel construction. A surgeon in transition can learn the steps of prolapsing of nucleus into the chamber and then removing it with the vectis during his conventional ECCE surgery. He then learns to do this by progressively making smaller limbal incisions. Once he is confident in these steps, he can then proceed to make a tunnel. Learning curve is reduced and smoothened if one passes to the following stages while transition from ECCE to SICS. Actually, we have a structured training program in which we have divided the learning process in 5 stages. The surgeon or the trainee learns each step in each stage. Once he is mastered in the one stage, then he goes to, or proceeds to the next stage. Now, stage 1 is a nucleus prolapse, which is the most critical step, and it's a new step for an ECCE surgeon. Stage 2 is a nucleus extraction. First, it is done through a conventional ECCE section. As he is mastered in this technique, then he goes for a smaller section, which is 8 to 9 millimeters. Stage 3 is the limbal tunnel construction. During the same time, he has to learn how to make a side port, an AC entry, and a wound closure. Stage 4 is a straight incision, and stage 5 is the final sutureless scleral incision. Now we will be talking about each stage in detail. Now stage 1 is a nucleus management. In this, the flipping of the nucleus into the anterior chamber is done. It is a new step for a ECCE IOL surgeon and is the most crucial step. The technique of flipping will vary according to the surgeon's choice and according to the type of the cataract. In the first stage of learning, a conventional large limbal incision is made. With a can opener capsulotomy, the nucleus is mechanically prolapsed into the anterior chamber with the help of a Sinskey hook. You can see both the videos here. In the one which is there on the top, I am trying to prolapse by placing the Sinskey between 11 and 12 o'clock. And in this video, it was by placing the Sinskey between 10 to 2 o'clock. The Sinskey hook is placed just behind the equator of the lens. The nucleus is slightly pushed down towards the 6 o'clock to get a better hold and then lifted up at the same time. It is rotated in a clockwise direction to get it out of the bag. Once one pole is out, the rest is relatively easy. Then the nucleus is removed by pressure and counter-pressure technique, and the rest of the steps are completed in the routine ECCE fashion. Stage 2 is the nucleus extraction. In the next stage, surgeon follows the steps as in stage 1 and then learns the technique of nucleus removal with the help of a vectis. You can see in all the 3 videos. The vectis is first, the cataract is cushioned by injecting visco. The vectis is introduced beneath the nucleus without damaging the iris, and the nucleus is expressed by pressing the posterior of the section. The rest of the steps are completed in the routine ECCE fashion. You can see in both the videos here. that first we have placed the visco above and below the cataract, and then carefully the vectis is introduced below the cataract and the nucleus is expressed out. Now next step is the nucleus extraction through a smaller section which is 8 to 9 millimeters. Till now the surgeon was doing all the steps in the routine ECCE section, which was a larger section about say 10 to 11 millimeters. Now the section is reduced to 8 to 9 millimeters. Once the surgeon is confident in the above two steps, he has to learn to remove it through a smaller wound by reducing the size of the incision. It is possible to express the nucleus through an 8 millimeter limbal incision. The section should be closed with sutures at the end of the surgery because it's 8 to 9 millimeter in size. Now stage 3 is the limbal tunnel construction. Having gained confidence of removing the nucleus through a smaller limbal incision, the surgeon learns the basic steps of tunnel construction. During the initial phase, a limbus parallel tunnel is preferred since it is easier to convert to ECC at any point of time. Surgeon has to make an 8 millimeter limbus parallel incision which has to go 1 millimeter into the clear cornea. The tunnel is fashioned using a crescent and a keratome. This is a video showing a limbal tunnel construction. It is not a limbus parallel but it's a straight incision which is given near the limbus itself. A 1/3 to half thickness external scleral groove is made 1 millimeter from the clear cornea. Tunneling is done with the bevel up crescent blade. It should be uniform in thickness and extended up to 1 to 1.5 millimeters into the clear cornea. During tunneling forward, one should raise the tip and depress the heel of the blade to prevent any premature entry into the anterior chamber. You can see that this is a limbal tunnel and the surgeon is making the side pocket which is 1 to 1.5 millimeters into the clear cornea. During this stage itself, one has to learn how to make a side port. A side port entry is made between 10 to 9 o'clock position in the clear cornea and is 2 millimeters wide. The purpose of the side port entry is it helps in aspiration of the subincisional cortex, reformation of the anterior chamber at the end of the surgery. Anterior chamber entry is done at this stage itself. It is done with a 3.2 millimeter angle keratome. The heel of the keratome is raised until the blade becomes parallel to the iris plane, resulting in a dimple on the corneal surface. The keratome is then advanced anteriorly in the same plane until the anterior chamber is entered and the internal wound is visualized as a straight line. Thus, a good corneal valve is constructed if the surgeon proceeds in this manner. A canopral capsulotomy is done and the nucleus is prolapsed into the anterior chamber and is extracted using an irrigating vectis. Since it is a large tunnel, it has to be sutured. Subincisional cortex aspiration should be done with the help of the side port at this stage itself. Next step is the wound closure stage. The most important step when closing the scleral pocket incision is to incorporate the deeper shelf of the sclera in each scleral bite. Deeply placed sutures produce greater wound stability and lesser postoperative extremectism. Good apposition of the inner edge of the incision speeds up healing. Now stage 4 is making of a straight incision. Having learned the technique of limbal tunnel incision, limbus parallel, now one has to proceed to a straight incision. Surgeon slowly learns to make a scleral groove straighter. The tunnel size remains larger and is closed using the suture. Now next stage is the sutureless scleral tunnel construction. Having mastered the prolapse and removal of the nucleus through an 8 millimeter scleral tunnel, the surgeon can over a period of time reduce the incision to 6 or 6.5 millimeters. You can see that this was a frown incision given and the heel of the blade was depressed and the tip was raised. Now steps to be learned later. First, after mastering all these techniques are learned using a can opener capsulotomy. Once you have mastered all these steps, then proceed to learn a rhexis. While doing a rhexis, the chamber is deepened with the viscoelastics. The capsulorrhexis is performed through the side port or a main tunnel using a capsulotomy needle or a forceps. Restrict the size of the rhexis to 6.5 millimeters. You have to be very careful. The rhexis should not be small in case of SICS because here we have to prolapse the nucleus into the anterior chamber. You could see the video, all the videos we showed all the rhexis in different direction. One was clockwise, one was anti-clockwise using the main tunnel or using the side port itself. In some, we can take the help of dye to stain the capsule and do the rhexis. During the initial phase, I think staining of the capsule plays a very important role. steps which can be learned later is also hydroprolapse. It is a two-step procedure. One is to inject the fluid and second to press downwards while injecting the cannula. The combination of mechanical and hydrostatic forces causes the opposite pole of the nucleus to pop out of the capsulorrhexis margin. The rest of the nucleus can be dialed out of the bag easily. After mastering all these techniques, we can learn the different techniques of nucleus delivery later on. One is the phaco-sandwich technique, the other is phaco-fracture and Frown incision. Frown incision basically helps in reducing the astigmatism, but one has to proceed to this only after learning how to make a straight incision. Phaco-sandwich and phaco-fracture are the techniques which will be dealt in later by the subsequent speakers. Surgeon learns one step of the surgery at a time and learns the next step only when he is confident about the first step. This stepwise transition from ECCE to manual small incision cataract surgery helps the surgeon in being more confident in managing various types of cataracts. By strictly following the above mentioned method of self-learning process, a surgeon who is confident in his ECCE technique can learn manual SICS with minimal complications. Thus, learning curve is drastically reduced if one starts practicing the crucial steps of SICS during his conventional ECCE technique. Thank you.